Welcome all delegates. This is Dr. Sarita Naik Narang from Mumbai. I'm a practicing urogynecologist and a vaginal surgeon. Today we are going to see some surgical procedures related to mid urethral slings. Just a basic introduction to the slings. They are based on the concepts of the bi-integral theory. Mid urethral slings replicate the natural mid urethral backbone as well as they provide the lateral bands which replicates the lateral hammock, and therefore they support the urethra in cases of incontinence. Various types of synthetic transvaginal mid-urethral slings which are available in market are retropubic, which is either TVT, the original TVT, or TVT Exact, which is the latest version by J&J, and also iStop, which is more of a non-deformable sling, more of a non-stretchable sling. There is obturator version of the tapes, which is either outside in, the TOT, the standard Lotus TOT tape, the inside out, which is TVTO by J&J, and TVT Ebrevo, which is a smaller sling, also by J&J. Also, mini slings and mesh plasties has been done in past in many patients, but these are the ones which we'll be focusing today. Whatever surgery we do, there are certain steps which are very standard in these procedures. Now, mid-urethral slings, they involve full thickness vaginal incision at mid-urethra. They need a periurethral dissection. If it is a TVT or a retropubic dissection, then the direction of dissection goes more towards 11 o'clock and 1 o'clock, while if it is obturator, the dissection will be a little bit more lateral, maybe 10 o'clock and 2 o'clock on both the sides. The trocar passage and mesh placement is common in both beneath the mid-urethra. The positioning of sling without tension is the key, and placement of mesh is in direct contact with the periurethral tissues. It goes without saying that all the failure rates, bladder injury, and possibility of mesh erosion has to be explained to the patient. The first tape which was devised was TVT, tension-free vaginal tape. It is retropubic, it is 40 centimeter long, and you can see how closely it is associated with bladder, therefore cystoscopy is mandatory. The original TVT trocars and needles were very thick, very big, and it was quite a work to do a dissection beneath the pubic area to let these big needles pass, but the advancement has made them much sleeker. The second category, transvaginal transobturator slings, they can be inside out or outside in. Both ways, whether it is inside out or outside in, whether you are used to do a TOT or a TVTO, eventually the tape is the same. It has to be the same. The positioning is same, the concept is same. It's only whether you want to put it from outside in or from inside out. Eventually the tape will function the same way. For outside in, the incision goes externally from obturator area. These curved needles, they go inside and then they pull the tape both sides outwardly, and therefore the sling goes and attaches below the urethra in this way. Advantage of obturator tape is that they avoid the space of radius and they reduce vascular and bladder injuries. Similarly, the inside out approach is going from inside vagina and coming out at obturator. Both ways, both procedures are equally safe in experienced hands. It's just that what suits in whichever doctors or surgeon's hand. This is TVT Ebrevo. You can see the same curved needles, which are same as inside out TVTO, just that the tape is small. You can see a loop, a central plastic loop as compared to a TVTO tape. It actually tells us that the tape is equidistant on both sides. The TVTO kits comes with the winged guide, and the slight difference between the two kits, we will see how it goes. TVT Ebrevo is 12 centimeter long, less groin pain, and efficacy is almost similar. Thumb rules of these surgeries. All incontinence surgeries start with empty bladder and they finish with empty bladder. Marking the entry and exit incisions is the key for a good surgery. One should feel for vaginal perforation while you're passing the trocars and needles. Leakage of clear fluid from the exit wounds or from the urethra or from vaginal area is a sure shot sign of perforation. To keep the sling tension-free, one instrument space has to be kept between sling and urethra while adjusting the tension. Now let's have a look on the kit. This is a transobturator tape, TVT Ebrevo kit. You can see that the kit is pre-packed in a very sterile way. The packaging comes in this way. You can appreciate the length of the plastic sheets which are covering the tape inside. So each needle has a handle and a curve at the end. One has to identify the sides of the needles. One has to keep the kit ready before starting the surgery. The kit has this winged guide, and you can see the two outward going needles, curved needles. They cannot be like this. They cannot be like this. That's why orienting yourself with the kit needle is very important. As you see that I have been holding the needles with the curve, the groove on the top surface. My thumb is holding the needles from the groove on the handles, so that's why it is up, while the curve of the needles is facing outwards. And that's how when I turn towards the patient's side, this needle will become patient's right and this will become patient's left. Now, marking the incisions and understanding the anatomy. First of all, it is important to find the landmarks. So mark the clitoris, figure out where the urethra is, mark the uretrovesical junction, and between urethra and mesourethral junction, that means point AA on anterior vaginal wall from POPQ system is the same. This is the urethral length, and this is where we will be putting the sling. Now, once I have understood where the entry point will be or the vaginal incision will be, which will be around 2 centimeter in midline on urethra, which marks mid urethra, while my exit wounds will be below the adductor longus muscle. So the landmarks are adductor longus muscle, clitoris, urethra. Now, I need to mark my incisions on the groin or the retropubic area or the suprapubic area based on which tape I am using. If I am using a retropubic tape, I'll be marking the exit wounds here, and if I'm using a TOT, I'll be marking the exit wounds here. Now let's just understand that how the tapes will be placed. If it is a retropubic tape, it will make a V below the urethra and will exit through here, while if it is a transobturator tape, it will make a U and it will be more obtuse. I would like to tell the exit wound markings here itself. For retropubic, 3 centimeter from midline, both sides. The exit wounds are marked here and a stab incision is done here. While for a TOT, the exit wounds, or for a TVTO, the exit wounds are at level of clitoris in the groin fold below the adductor longus muscle. With markings in place, we give the incision. So a midline 1 or 2 centimeter vertical incision is given. Infiltration can be used based on surgeon's convenience, and at the same time the groin stab wounds are made so that we know where our needles will be exiting. Now you can see here that the next step is to, after making an incision, then we put the winged guide. The winged guide will go in a direction where my needle has to go. So if I want to do a TOT, my wing guide will be going towards the shoulder of the patient. So my right side needle, when it needs to enter, my wing guide has to be in place and it has to point towards the patient's right shoulder. Now, once I have put the wing guide, perforated to obturator membrane, I'll keep it fixed and then I will proceed with my needle. So you can see that the curved needle is going inside. My right hand is fixed and is keeping the wing guide in place. The thumb is assisting the curve of the needle to go inside. The wing guide is protecting the urethra. And once 2/3 of needle is inside, I will change the hands. Before pushing any further, it is important, as I highlighted in the beginning, that feel the vagina for any perforation of vagina by the needle itself, because many times it's the primary vaginal perforation which is later on misdiagnosed as vaginal erosion. So we feel inside, we should not be feeling any plastic or any metal in the vaginal area, and then I exchange the hands and then turn and twist and bring it out from the exit wounds which are pre-marked. So you can see that exit wounds for my obturator tape is already marked and once my needle comes out, I twist and turn out my needle and take it out. Again, one has to make sure that I have not perforated any vagina, so I don't see any white plastic sheath in vagina, and then I will pull out this tape, the sheath, and this is how the tape will go in place. This one is TVT abbrevo, otherwise the TVTO is exactly the same, just that the length of the tape is more. Now the same thing has to be done on the other side. The urethral flaps, the vaginal flaps are picked up. And the space will be created. You can see how we are giving an incision on the other side also. This was the same way how the paraurethral tunnel was created on the right side, and this is how we are doing it on the left again. Now once this dissection is done, the wing guide is again pushed in on the other side, and the other side needle is inserted. The needles are made in such a way that the tip of needle and the base of needle are not on the same level. Therefore, when you rotate and twist it, it will come out exactly at the point where you want it. So again, once I'm inside, I've gone in, 2/3 of the needle is inside. Once it is there, I will be changing the hands. And the needle will come out exactly where I want it to be. From the exit wound, which I have marked already below the adductor longus muscle. So you can see that pre-marking the incisions helps so much. And now the assistant has pulled the sheath and the tape is in its place. Now this is what we are doing now, is adjusting the tape. The loop of the tape in the center helps us to understand that we are not pulling more on any one side. It is very important to keep an instrument between the tape and urethra so that we don't end up over tightening and the tape is just snug to the urethra and it is not creating a band. Now the packaging of J&J, TOT and TVTO is like that the tape is covered with plastic sheath. It is very easy to pull the tape, tighten it, loosen it till the sheath is inside. Once you remove the plastic sheath, you can't really do much. So we have to be very careful that adjusting the tape without tension, being the most important step, should not be overlooked, should not be done in a hurry. So you can say that my artery forceps is lying right between urethra and the tape. It is just adequate. It is neither loose, neither very tight. And once it is done, I have cut away the ends of the sheath and then the plastic needs to be pulled out. So you can see I'm pulling the plastic sheath now by using our artery forceps. One side plastic sheath is removed and then second side sheath is again removed. You can see the proline anchoring threads which are coming out from the exit wound. In the end, we remove these threads while keeping the instrument in the center, because even while we pull out this, the tape can get unnecessarily tight. This is the surgery almost completely done for a TVTO or TVT abbrevo. The Rolling thread is removed from both the sides and the loop is cut at last, and then the wound is stitched by Y320. Now the second tape which I want to show is TVT Exact, which is the latest version for TVT. The needles have been replaced by sleek armed sheaths. They are one-time use and throw. They cannot be autoclaved again. That's why the cost of implant is a bit more. The incision in the vagina stays the same. It is same as like 2 centimeter below the urethral opening in midline, while the top incisions will be at the suprapubic level, like I said, 3 centimeter away from midline. Now here you can see how we arrange this kit. There's one trocar, and you can see that there is a hook at the base where the sheath is locked so that it doesn't slip away. So once it is locked like this, it is ready to be inserted. Now here you will see that I have made an incision, and there is something different than a TVTO, that this long guide wire, not say guide wire, it is called Foley's catheter introducer. So it's a long wire kind of an instrument, a stiff instrument on which a Foley's has been covered up. The instrument is inserted into a Foley's catheter, and then this is to be placed inside urethra and bladder to deviate the urethra and bladder away from the track of this needle. So in steps, which is the step which is different is to retract away the bladder and urethra from the path of the needle. Now once this is inserted, the assistant will keep holding it away from the direction where I want to put the retropubic tape. So if I am doing patients right, the assistant hand will keep this particular device, the Foley's catheter introducer, to keep the bladder towards the patient's left so that my path is clear. Now here, after creating the tunnels, there is no winged guide here, because here we are going right from below to retropubic area. So there is no winged guide, but we go from below at a position of around 11 o'clock towards the patient's right shoulder, and you can very clearly see the exit wound. This is the exit wound for retropubic TVT, and you will see that the exit wound is in midline around 3 centimeters or 2 finger breadths laterally, right in the crease of the lower abdomen. So this is how the TVT retropubic entry is made, and the needle comes out from the exit wound. Rest is same, like the assistant has pulled the TVTO here also. The tape will be pulled out, and all the time my finger will keep feeling that whether it is going in a right way without getting twisted, and there is no vaginal perforation. Now once it is there, the same thing is repeated on the other side. So you can see that the same procedure will be repeated other side, and the wound, the needle will come from the top. At the end, the tape will lie like this, while both the ends are on top, and I'll be adjusting and pulling them. You can see that we have kept again one instrument to keep this tape without tension. Now here you can see that both the tapes, both sides have come up there. One instrument is right in the middle, behind the tape, between the urethra and the tape. It is adjusted without tension, how snugly it is lying there. And then rest of the procedure stays the same, but in TVT, cystoscopy is mandatory. So when we do cystoscopy, we check inside the bladder and we make sure that the tape is not inserted, accidentally perforated the bladder. Now, bladder perforation, the risk is 0.5 to 4%. It is not negligence, but failure to identify is a negligence. Signs of bladder perforation in a case like this, or where we go very close to the bladder, can be either they can be hematuria, which may not always be present. There can be a visible perforated tape in the bladder, like this, that you did a cystoscopy and you discovered, but many times you may not find anything and still there can be a perforation. A leakage of water, a saline, either from these ends or from below, is a sure shot sign. Now this was one such case where after doing cystoscopy we were finding everything normal, but there was a constant leak of water coming from here and the patient was getting all wet on this side. And yes, while we kept on doing cystoscopy, trying to locate where this is water is coming from, we actually could identify that there was this needle and thread effect where the two leaves of the bladder, they got so close to each other. If you see carefully, this is one bladder fold, this is other bladder fold, and the tape has gone through and through here, and that's why the water kept leaking from here. And therefore the tape was removed, and once removed we could identify the two holes in the bladder. So yes, bladder perforation is not that uncommon. It can happen even in very good hands also. In such cases, we just keep a catheter for 48 hours. We don't really repair these tiny perforations in the bladder. Other complications can be hemorrhage. Sometimes going too extensively towards the abdomen can cause bowel urgency. Groin pain is more common with transobturator approach. UTIs, voiding dysfunctions, and de novo incontinence can happen in 5 to 10% cases. Post-operatively, you have to follow a catheter protocol, most important being measuring the residual urine volume, which should be less than half of voided volumes. Generally, less than 150 ml is acceptable. It is important to understand that if a patient is totally unable to pass urine, it's time to loosen up the sling, which can be done within first 24 hours. Some cases which are important. Missed extrusion in vagina. This was a patient who came to us after the surgery within 2 weeks with wound breakdown, and the complete mesh was lying exposed in the vagina. So we had to remove this mesh. I had to dissect it. It is easy to remove a mesh within first 2 weeks. After 3 weeks, the complete mesh can get fibrosed. So here the entire mesh was dissected back and had to be taken away, because it was completely exteriorized in the vagina. So this is how we had taken it out, and this was that whole crumpled mesh. Basically the mesh was getting rejected and got infected, and therefore it was removed. Another case, post-surgery 5 years, we saw this in OPD. A patient which was done somewhere at periphery, no details were available, but you could see and feel exactly below the urethra, the entire mesh lying open there. We did a vaginoscopy and we could closely see the extent of the mesh. This is vaginoscopy. Don't mistake it for cystoscopy. This is vaginoscopy. This was cervix. And while examining vagina, we could see this old infected mesh lying completely exteriorized. The epithelium below the mesh was also full fine. So it was a long-standing rejection of tape. And for this, we had to really do a lot of hard work, because to dissect it out from paraurethral space was very difficult. We could do only minimum, that we had to just separate it from vaginal mucosa and remove it as much as we could. So we did remove this mesh and patient was symptomatically better. You can never remove these meshes entirely, especially from the transobturator area, because they are very close to adductor vessels and even the bones. So this was the case where this tape was removed after 5 years of surgery. These were the strands which were towards the end. It was very difficult to remove them entirely. Its and bits we could do this, and we could remove this much piece of the mesh. So many times we had to see whether it was a true erosion or was it a tape rejection in the beginning itself which was missed. So this patient was treated further for antibiotic covers and vaginal estrogen. Mesh erosion in bladder is not that common. They are generally missed perforations which later on form stones, form crust in the bladder, and they are picked up later on by urologists while investigating for recurrent UTIs. But yes, they can happen. Choosing between TVT or TOT, different research, all the research, what is coming, slowly is saying that the TVT has better outcomes over TVTO. TOT is more commonly used in India. Choose your tapes wisely, but yes, I will suggest that if your patient is obese, has chronic cough, chronic constipation, has coexistent intrinsic sphincter deficiency, previous failed surgery, please prefer a retropubic tape, which is far more effective than a obturator tape. The only advantage of a TOT is the cost, which is less. Also, you can escape doing a cystoscopy, which I personally do not advocate. I feel any person who is doing an incontinence surgery should be doing a cystoscopy also. It's much easier to learn than a dissection of TVT, and easily available, I'll rather say. It's more about surgeons' comfort, training, and experience. Most of my cases, they opt for TVT. I choose TVT for them, while there are some cases where we still do TOTs. Thank you.